All right, yeah, welcome. I'm Shane Longman. I'm the addiction consult service for the hospital. Every couple of years I give talks on what I do here. And the reason why I thought it'd be a good idea to do this one again is because there's some success with Sublocade that we have that I just wanted to share with people that is just such a game changer. So Sublocade is the injectable form of Suboxone. Suboxone is a partial agonist that partially fills the receptors of the opioid receptors, such that people who use fentanyl or other opioids who have substance use disorder with them, if they don't use anything, they go through withdrawals. They need to fill it with something. There's lots of options on what to fill it with. The best options are ones that are long-acting, that do not enhance the addiction in any way. So there's things like Cadian, which is very long-acting morphine. There's a methadone, which is also a very long-acting opioid, and there's Suboxone, which is a long-acting one, which you can, if you take it under the tongue, is good for 24 hours, as an average. Sublocade, however, is good for 28 days or longer. And in fact, it lasts much, much longer than that. It's not uncommon. If we give someone a shot of Sublocade, if we test them for Suboxone for the metabolite of it in their urine, 3 months later, it's still there. Now, the reason for that is that the shot is, it goes in as a liquid, but it changes into a gel. And we do it around the belly button predominantly, although it doesn't have to be around the belly button. It can be in other places. It can be in the fatty part of there. It can be the fatty part of behind the leg or the buttocks. So there are other places we can give it. But preferentially, we usually do it around the umbilicus. And we don't do it in the same spot 2 times in a row usually. We usually try to move it around. But when we give it, it goes in as a liquid and turns into a gel. When it does that, it gives off heat. It's an exothermic reaction. So it can be uncomfortable. And when it's uncomfortable, that's why I use this. So like people were using cold packs, people were using various things to try to make it better, an ice pack on it, but they don't get cold, they don't get the belly cold really fast or very cold. And the colder it is, the better, because when it gives off heat, when the injection gives off heat, if it's near a nerve, it can really burn and it can be really uncomfortable. So I thought, when we wear gloves, we're wearing gloves because we can therefore feel the temperature of people, like if they have an inflamed knee or something, we can feel whether there's heat there because the temperature goes through it. So I thought, well, if it goes one way, it can go back the other way. So the cold goes through it really, really well. So I decided to use gloves to see. I don't know. I don't know if anyone actually does it on the other. I keep forgetting to ask the other addiction medicine doctors if any of them do this, but I'm going to suggest it because it works so well, and it's way easier to do that than it is to find an ice pack somewhere. So anyway, that's what I use. So we put it on. We make it cold, very cold, as cold as they can tolerate. Some people can't tolerate it super cold, but as cold as they can tolerate, because if it does heat up and it's near a nerve and it is very uncomfortable, that might be enough for some people not to want to get it a second time. So we try to make the first time as comfortable as possible. The first shot we give, and then we give the second shot about 28 days later. The reason why we do 28 days is that's approximately how long it lasts with a serum concentration of the Suboxone at close to the therapeutic level of the 100% of what we're expecting. And then it starts to go down, but it doesn't turn off at 28 days. It just starts to go down. So we give another shot at 28 days. We've got one now at 100% and one less than that, depending on the person how much, but maybe 90%, something like that. So now we have 2. One's at 100, one's at 90, 190%. of what the previous serum. Gradually over time, we can sometimes extend it to 5 weeks and even 6 weeks. Alternatively, we can go down in dose from 300 milligrams down to 200 and then maybe down to 100, and then we stay there for quite a long time. It really depends on the person's situation, which way I choose. If a person lives a long way away and transportation is difficult, I try to keep it at 300, and because that way we can extend it to 5 weeks and then 6 weeks, and it's less travel time. Or if they really don't like injections, then it extends it much further. Or if they work, on like a fishing boat or something, and they don't get in very often, then it extends it even more for them, makes it more convenient. However, if a person is really, really thin, if you're really thin, you want to you grab the skin and you pinch and lift. You pinch, lift, and then inject into that spot, in between the skin and the muscle in the subcute. And people with a little more there, it's more comfortable. It cools down more with the ice. It also tends to be less painful even when it does heat up a lot for them. So it's better. But people that are really thin, it's uncomfortable, more uncomfortable. And plus, they can really feel that lump because there's just not a lot to hide it. So for those individuals, I try to start reducing it as quickly as I can, down to a lower level. But it really depends on the person. And so it's always a conversation. And they get, go ahead.
So interrupt, how do you know the levels? Is there a blood test? Is there something so you don't really know the levels, you just kind of guesstimate the levels?
We know the levels because of the literature in terms of what typically it is. But we don't measure it.
Yeah. I was just wondering, because some things are measurable, right? Some things are, I was just wondering. Okay.
I've never asked to have it measured. And the main reason for that is that I don't really care, because it's whether or not they're in withdrawals and whether or not they get cravings and whether or not they use.
So that's really how you monitor it.
That's really how I monitor it.
I was just wondering.
I monitor it based on effect. Yeah.
Not that I'm in.
And then the doses, are they weight-based, or do you always start at 300 milligrams?
Always 300.
Okay.
Yeah. Now, not always. If a person is using a crazy amount of fentanyl, I will give 300, but I have a low threshold for giving more, like days later or a week later or something like that. If they're using, so some of the terminology. So a ball is like 3.5 grams. That's so if there's it's commonly talked about as points. A point is 1/10 of a gram. So there's 10 points to a gram, so that would be 35 points. Points can be $20 a point. So we're looking at quite a lot of money and an awful lot of substance. So depending on how much a person says they use, I would have perhaps a low threshold for giving more, because it may not fill all their receptors. Their receptors may be crazy high, and we just may not have success. So in a case like that, I may have some of the Suboxone under the tongue for them as needed, so that if they do start going through withdrawals, we give some of that to top it up. Or I may give a second injection of a lesser amount, like 100 or something, just to add some more. I might also give them some clonidine or some Ativan to tide them over, because you don't give the injection and immediately it's die. I mean, it takes half a day or 6 to 8 or 12 hours to get up to the blood serum level before they get full effect of it. And so I often will give them some clonidine and some Ativan, especially for that first day, while we wait for it to get up to the therapeutic level. Not everybody that we give Sublocade to is at the same stage of withdrawal or of abstinence when we do it. Some people come in and they haven't used for a whole day. They're sweating, they're like in full-on withdrawals, and they're like, yeah, I haven't used for a whole day, I feel terrible. And the story fits how they look and everything. So in a person like that, if they're in full-on withdrawals and if there's very little bound to the receptors, then I can give them the Sublocade, but it's going to take 6-8 hours before it fills everything. So for them, I might give them a full dose of Suboxone under the tongue first, just to fill their receptors in 10 minutes, make them feel way better. I might also give them some clonidine and some Ativan just to take away some of the what they call down sickness. So the aches, muscle aches and pains, the sweats, the agitation, all the bowel symptoms. All they may have. If they have those symptoms, I want to make them feel as good as possible, as fast as possible. So I may give them some Suboxone under the tongue and the Sublocade shot at the same time. That way, we've covered them immediately and we've covered them for 28 days. But if it turns out that we need to give them some extra, I'm not against that either. It's just about making them comfortable. So a couple things come about this is that they may not be in full withdrawals when they come in. They may have used just beforehand, or 6 hours beforehand, or 12 hours beforehand. So there's going to be varying degrees of presentations, but we don't want to lose the opportunity to be able to get individuals started on OAT, the opioid agonist therapy. So it's been a thing that we've been doing a lot more in the last couple of years, is that we give Sublocade regardless of when they've used. If they go through withdrawals as a result of it, we can manage that with medications and make them feel better. And besides which, as if they've never gone through withdrawals before. So usually what I just do is they will come in, so they will sometimes come into the shelter on Friday, and they will say, yeah, I used an hour ago, but that's the only way I was going to make it here. I want a Sublocade shot. I go, all right. So this is what might happen though. You might go through, this might be a really tough day for you today. You might be feeling pretty sick, you might have some withdrawals. I can give you stuff to help, but I just want to make sure you're aware of that. I mean, and if you agree, then let's go ahead and do it, because I'd rather have you do that than die. And some people will say, yeah, I overdosed 3 times this week. If I don't get on this stuff, I'm going to die. And they said, what's 6 hours of withdrawals compared to dying? Now, 6 hours of withdrawals is still bad for some people, but better than dying. And the thing is for some individuals, if they don't have a ready supply of funds or a ready way of getting product, they're in withdrawals lots anyway. So they already know what it feels like. And they already know so they're well prepared to say, you know what, I'm fine with being in withdrawals. Thanks for the Ativan and the clonidine to help with the withdrawal symptoms. I'll wait it out. So there is ways so some individuals just decide to do it anyway, just because they want to get on it. Now, why would an individual, and the reason why the individuals say that is they also know themselves. And they go, yeah, I've tried the microdosing. So microdosing is starting off really low and then increasing over a number of days until you get up to the maximum amount. Different people have different microdosing protocols. The hospital protocol for microdosing is, in my opinion, ridiculously slow. It's really conservative. It's recently been changed and increased to be a lot faster, but even then it's not as fast as what I do. I go way faster than that.
Microdosing of what?
Of the Suboxone.
Of Suboxone.
So if we're trying to get to a dose of, for instance, 24 milligrams, which is a common one that we try to get to, on day 1, we might start at 0.5 milligram 4 times that day. So that's a really small amount. I mean, it's a total of 2 milligrams over the course of the whole day. But if we give much more than that, we might put them into a precipitated withdrawal because there's Narcan in it. And Narcan might put them into a withdrawal. So we have to be careful how we do it. We don't want to turn them off the idea of Suboxone, because we never want them to say, I'm never taking this stuff again. We never, that's something, we don't have to overcome that. So we'd be very careful in terms of, with the microdosing, of going up in such a way that it's hardly noticeable. And that might take, commonly that'll take 3 days as an outpatient. And then sometimes they will be at 24 milligrams of Suboxone and they'll be like, yeah, I'm not using anymore. And I go, Great, exactly what we were expecting. Let's give the Sublocade. Now that was the preferred way of doing it because there's much less chance of any precipitated withdrawals, but not everybody can do it. Some people use crystal meth at the same time, or just have not a stable lifestyle or a stable place to live or anything like that. They may not be able to take it 4 times a day for 3 days before getting up to 24 milligrams on the 4th day. They just know themselves. They say, yeah, I've tried 3 times. I never make it there. So they say, just give me the Sublocade. I'll deal with the consequences, but tomorrow I'll be better. And they would prefer that. And the other thing, of course, is that they know themselves because success is not measured as abstinence. Success is less likely to die, less likely to harm yourself, harm others, and rebuild relationships with the people that you've lost relationships with. Rebuild your self-worth, rebuild your link with society, and in doing things. That's success. Success doesn't have to be don't use anything at all. Of course, that's what we prefer, but it's not what I certainly don't expect that, because I don't want any expectations on my part to make the other person feel like they've not succeeded. Success for me is anything less, using less. Using none of all of fentanyl, but using crystal meth is still success. Better than using both. But if they are using crystal meth, they may be out of it for a bunch of the day, in which case they may not be able to do the microdosing. So that would be an individual that I would have that conversation with of, how can we make this work? And they may say, yep, it won't work. Let's just go straight to the Sublocade. So I've been doing that a lot, just straight to Sublocade. It's great. I'm thinking I must have given like 100 straight to Sublocades now. And I would say I know of one that did have withdrawals. Most either had no withdrawals at all, or withdrawals were so minor that they hardly mentioned it. They said it wasn't a concern to them. It does, of course, depend, as I said before, where they are in their stage. If someone's in RCMP, so I go to RCMP cells, and if I get called by RCMP and there's someone in there that is in withdrawals, I go to see them. And I will sometimes bring Sublocade with me, because if they've been there for 24 hours and they want to be on Suboxone Sublocade, I can arrive, describe it all to them, make sure they understand it, and give them a Sublocade shot in cells. Because 24 hours later, they're going to be in like the worst withdrawals they've ever been in. Now, I also, at the same time, would ask the pharmacy to bring by 24 milligrams of Suboxone so that we can make them feel good right away. It's advantageous because not only have we now started on something that's going to be good for 28 days and give them a running start of having success, but they've also now got a very positive opinion of me coming into cells. Like, the relationship building is really good. They also really like the fact that RCMP actually called for me to help, because they go, wow, usually we have bad opinions of RCMP, but they called because they wanted me to get better. And they kind of like, wow, that's good, I like that. It has made a big difference in a number of situations. RCMP have gone by to arrest someone, and they know from past that this person will resist. They will run, and if they catch them, they will fight. And so they're going to go arrest them. And it's like, and they bring a few guys in, and the guy or girl yells out to them, "It's okay, I'll come, but you're going to call Dr. Longman, right?" It turns out the reason they were fighting and running wasn't because they didn't expect to get arrested. They knew they were going to eventually get arrested. They knew it was coming at some point. They just didn't want to go through withdrawals. But when they knew that I would come and give them something so their withdrawals would be better, they would then not fight, and they would come along. And the RCMP told me this. They told me this. That's how some of the conversations go. Obviously not everyone, but But that's how bad the withdrawals are, is that they'd rather throw a punch at RCMP than just be let off. Not the best decision usually. So that's an idea of some of the situations. So I arrive and they're in terrible withdrawals. We make them feel better. They have a better response with their lawyer. They have a better response with the judge, who then, over video or whatever like that, they have a talk. The person's actually able to give their side of the story. Whether or not it's reasonable is obviously up to the situation. But at least it's not a matter of the person on the other end in complete withdrawals, just doesn't want to hear anything, just is like sitting there, just suffering. If they're prompted to answer like that, they just blurt out obscenities and stuff like that, because in a case like that, the person might have been eligible for coming back at a later date, like on their reconnaissance, and be able to come back. But if you don't answer any questions, you just go to jail. And if you go to jail, that costs the taxpayers more money too. So there are times when individuals could, if the situations are of course appropriate, could be released to come back. But if they can't talk, then that option's gone. So it also helps with that. So those individuals also think, wow, that was, they're really grateful that there's this opportunity, and they also feel way better. So then they parlay that into coming back and seeing myself or a substance use nurse or someone more often, because they go, actually this stuff did work. Sometimes that's the first time I ever meet individuals in the community, is in cells. They know that I'm at the shelter. They know that I'm at but they never come. They don't want to come for whatever reason. It might be they don't believe in it. It might be that they just don't want to face it. It might be that they've heard things that are incorrect about the medications. And there are lots of rumors about the medications. I mean, some of the medications is that these medications rot your teeth. That's a very, very common thing that I hear, is that, I don't know about the methadone though, it rots your teeth. I've seen people that are on methadone and their teeth are all rotted. I go, well, it's not methadone. This is how it works. You use crystal meth for 5 years, and you don't brush your teeth for 5 years, and you don't look in the mirror for 5 years, and then you start methadone, and you stop the fentanyl, you stop the crystal meth, and life turns around and you're feeling way better, and you go, okay, I'm going to start looking after myself. You look in the mirror, my teeth! Well, that's the first time you've seen them, because it's the first time you've paid any attention to them. The correlation, of course, is that I started methadone, looked in the mirror, saw bad teeth. But it wasn't the methadone, it was the 5 years of crystal meth and of poor dental hygiene. So there's lots of false things about Suboxone and methadone and stuff like that people will that we have to overcome. Another thing we have to overcome is the stuff that's on the street. So Suboxone, people get Suboxone, and I don't restrict it to like must pick up every day and be witnessed every single day. Not for Suboxone, I don't. I mean, I encourage it at the beginning just so that I get an idea from the pharmacy, because I can look on PharmaNet and see if they've taken it or not. And also it encourages me because some of the pharmacists are really good at asking more questions and seeing how things are going. So they're part of the healthcare system, not just dispensers of the medication, but they talk to the patient, and they ask other questions, and they make sure, and then they relate it back to me, and they will tell me if things are not going right or if there's a second thing happening. So it's really good. I have some good relationships with some pharmacists that really help a lot. But what was I saying about the pharmacists?
I don't know that question.
What was I saying about them?
Watching the...
Oh yes, Suboxone. So I don't make it a daily witness every single time, because it's difficult. And it's not comfortable, and some people feel embarrassed. Some people don't like being judged. They don't like, well, of course, no one likes being judged. But the point is that you have the potential for being judged. And not everybody thinks anybody else knows about this. There's lots of individuals for whom this was a secret. Their partners didn't know about it. Their workplace didn't know about it. They they made it through. They're not fired. They're not living on the street. They're still making. They still have a job and they're still working. They now use a small amount to get through the day every day. They're no longer getting high. They're no longer partying with it. They are using the least amount they can use to just not get sick. And for them, they would rather their co-workers and everybody else not find out. So they love the idea of a Sublocade shot because they don't have to go into the pharmacy and pick this up at all. They come to see me, they don't even have to pick up the Sublocade. It gets delivered to my office. So they just come in to visit me, get a Sublocade shot, leave. 28 days later, I see them again. They don't have to answer any questions. Previously, they would have to use half a point first thing in the morning, and then they would leave for noon, and they'd say, yeah, I'm going home for lunch, and they'd use half a point at lunch just to make it through the afternoon. Then they use half a point after work, and then half a point before they go to bed, just so that it's spread out and they don't go through withdrawals the whole time. But then the boss says, no, I need you to work through lunch. We got to get this job done, or I'm sending you out of town for this. And they're like, and they're trying to come up with excuses. So I had one guy, for instance, who bought a puppy. Not because he wanted a puppy. He wanted an excuse to go home at lunch in order to be able to use his half point so he didn't get sick. I mean, I'm sure he liked the puppy too. But the point is that he was able to look after the puppy. He was able to look after, his job. He was able to do all this stuff. But he really didn't want anyone to find out about this. And his supplier was changing. He started getting a little bit more or a little bit less of it than he was used to, and he was feeling sick. And that's what prompted him to come see me, is because things were hard. So daily witnessed is not something I would have someone like that do. And I wouldn't have someone that lives far away do that and increase the driving costs, or someone driving them in. If I can avoid daily witnessed, I will. I can't avoid it with methadone most of the time until they're really stable, because it's too dangerous. If they have like 4 methadones at home, even if it's in a locked fridge, if they take their methadone in the morning, use a bit of crystal meth, and then hours later go, oh, I forgot my methadone, and take another one, it can reduce their respiratory drive. They could have an overdose potentially. So, and they may not be trying to. But, so therefore we give carries of Suboxone faster, more likely, and it is less dangerous. But there is a negative to that, and that is that some of these individuals that have carries, if they stop using it for a while, they have a supply that they're not using anymore. Or if they reduce their dose from 24 to 16 because they just want to try to go down, if they end up being successful at going down to 16, I may not find out for a few weeks when I talk to them again. And they say, yeah, I was able to come down from 24 down to 16. I thought I should let you know. I said, when did you do that? 2 weeks ago. Okay, so you have 14 extra 8 milligram pills. It's like, okay, we'll calculate that in. But if we don't calculate it in, or if I don't find out about that, they've got a supply of extra ones. Now, sometimes they want extra ones in case they are going traveling, or in case they feel like they might run out, or something like that. But sometimes they give them to friends. And they will give them to friends not to harm them. They'll give them to friends because the friends say, I'm so sick of this crap that I'm on all the time. You're on Suboxone and you're not using. I want some of that. So he says, yeah. And so he gives him 24 milligrams of Suboxone an hour after using, and he goes through a precipitated withdrawal. Worst withdrawal he's ever had in his entire life. And then he says, I'm not taking Suboxone ever again. Worst thing I've had. That's terrible stuff. Well, of course it's terrible if you take it that way. So now I've got someone who I have to undo that negative association with Suboxone because they were given it by a friend and it was done wrong. It's not impossible. I have lots of analogies, lots of things that I give, lots of stories so that people might be willing to try it again. But the number one biggest thing I need to do is gain their trust. And so I will go, that's a lot of what addiction medicine is a relationship building exercise. these individuals that use, not everybody, but the vast, like a majority of individuals, have lost an awful lot of stuff in their lives. They've lost their self-worth, they've lost the trust of their family and friends and their workplace, and they're not necessarily, they're sometimes targeted when they go into stores, or targeted when they, and when I say targeted, I mean they're immediately, when they come into Emerge, immediately the reason they're coming in is for drugs, or because they could have a broken ankle, and the idea of giving them pain medications for it might be a difficult thing for some healthcare professionals to think of, because they think, well, I don't know, we have to probably go low because they're just going to abuse them and we can't give any carries, well, that makes, I mean, although there may be some truth to not giving them 20 Dilaudids to go, there may be some truth to, being more careful. That doesn't mean they still don't have pain. And that also doesn't mean that, and what commonly happens though is that they will encounter negative impressions towards them, and they get really frustrated by it. And it's not an uncommon thing for individuals who will wait 3 to 4 days, see me in the shelter, and ask if I can help them in the shelter for something that should have been seen in Emerge 3 days ago. And then so I will explain to them that, okay, this is something that has to be done through Emerge. I think your wrist is broken. It looks like it's broken. Everything by history says to me that this is broken. And even if I order the X-ray, you may still need to get a cast on, or even a reduction, or even surgery. We need to go through the proper thing for this. But the only way we're going to get this done is through Emerge. But what I will do is I will call and personally talk to the Emerge doc, and I'll talk to the to the triage and explain what's going on. I will try to get it such that you're not waiting very long. And if you do have to wait, I will make sure there's some Ativan and some clonidine and some stuff there, so that if you start going through withdrawals, I have some stuff to help you out. That's a relationship building exercise, and sometimes I have to do that a bunch of times before someone will then allow me to help them with substances. One of the first stories that I remember of when I first was doing this and first seeing people was a guy who was he was from Port Alberni, but he'd moved to Campbell River because he was involved in some illegal stuff and things had gone wrong, and he was going to get the tar beaten out of him, so he just moved away to Campbell River. And he was a substance user as well, and he did some illegal stuff, and he became HIV positive through IV drug use. And he found out, and he didn't know, that their medications make it a treatable long-term life problem, but not fatal anymore. It's not necessarily. I mean, you can just live with it. So he didn't know this. He heard this and just lost his mind and was like, I'm going back to Port Alberni and I'm settling scores with everybody that I hate. He was such an angry guy. He just wanted to. So he came in and he needed some health care. He didn't have a doctor. He didn't want to go to Emerge like that. But the nurses convinced him to come see me. And he came in, sat down, and I said, hi, and I introduced myself. Hi, I'm Shane, or Dr. Longman, whichever you like. And I always go and I have to go, shake the hand. And he just put his hands off, leaned forward, this close to my face, and he's like, if you fucking piss me off, I'll be over that table and I'll fucking beat the shit out of you. I was like, okay, well, I'll be very careful not to fucking piss you off. And he laughed a little bit like this. Well, it turns out that he's living in a place, he's still using IV, he has parties, everybody's using each other's stuff, it's super high risk of lots of things. Doesn't want HIV meds, doesn't want to stop using, just wants to hurt people and then die. That's all he wants. He's just mad at the world. But he also loves watching movies, and he had a big collection of VHS tapes, and with a VHS recorder, playback, and TV, and he would watch movies, and he loved doing that. Well, during one of the parties, the TV got smashed, and he couldn't afford. I mean, he was on like assistance, so he got a certain amount of money, but it wasn't enough for him to buy a TV, and he also wasn't really controlling his funds very well, so there was no chance. On top of that, he got in trouble with the law, and he was given a deal whereby if he did a certain amount of community service and paid back for some there's a certain amount of money that he had to pay for some damage he's done, and then he had to be on parole for a while, and they would allow him to not go to jail. Well, there's no way this was going to happen, because he was spending everything all the time. He was just angry, and he didn't want to do anything. So then his TV gets broken, and I see him, and so I go, opportunity. So I said, you know what we're going to do here? I think we have a plan. Let's do this. If you want to work with me on this, I want to try to help you into this. I want to try to get you a TV back. I also want to stop you from going to jail, and I want you to fulfill all the things that you need to do. First thing we need to do is I want to get a trustee appointed, such that 10% of your assistance goes to that person for the first check, and then the second check will go up to 20%. I'll talk to your parole officer. I'll explain what's happening. We will put part of that money towards the fine that you have to pay, and then we're going to go down to the pawn shop and we're going to talk to the pawn guy and see if there's a TV that we can put aside for you. And then we'll pay it off week by week, small amounts like this. So we did that. And I went down to the pawn shop, I talked to the pawn owner, and he went, yeah, I'll do that for you. So he put it aside. And gradually, the TV started to get slowly paid off. Plus, the parole officer was like, okay, we're not meeting the objectives, but we're like doing something. So he went back to the judge, and the judge said, you know what, we'll extend things. I like the way this is going. So they extended a little bit further, gave a bit more opportunity, and he started to feel better about things. The pawn shop owner, after it was like 60% paid off, he said, this is great, you can just have it. And he just gave it to him. So he got his TV back. He stayed out of jail. He ended up doing the community service. He ended up paying back the fine. It took a long time. It took a while to do it, but he managed to do it. And then he'd be walking by the office or like that, and he'd wave at me like this. And then one day he came in and he said, and he sat down and he went, you know, you were telling me about this HIV medication this one, and this was like a year later, a year after I first started doing stuff. And so he was like, yeah, I want to hear more about this. So we got him to the point where he was taking HIV meds. He was still using IV drugs, but he put tape down the center of his kitchen table, and he told everyone, and he told me this, he said, I have tape down the center. He said, this is mine, this is the HIV side, you guys use that side. And so he separated all, he took responsibility for that. He definitely was using less drugs because he less angry, lots of other things that were going on. He still was using. He still wasn't a model citizen, but he was way better than things were. And this took a year of relationship building for this to happen. And that's actually the kind of time frame we have to look at with some individuals. It takes a long time to build that relationship to then get people to try stuff and to do things. They may have really negative ideas of the healthcare system and really negative ideas of addiction medicine, medications and things like that. So that relationship building exercise is often very, very key to it. We got about 10 minutes left. I should answer some questions if there's. I remember there was a question.
I was wanting to know how much is a shot of Sublocade? Because I know that in Victoria they were giving out 1,000 almost a day. When I went to the seminar the gentleman put on at the Barclay, and I was just wondering, and that's covered, it's not my business because I'm not using it, but it's just for curiosity's sake. I can't go buy insulin. We can't give insulin out, but we can give this because it's preventative, and I get that.
Yeah.
And do you know how much a shot is?
It's hundreds.
So that's not thousands.
No.
I mean, I was just wondering in the ballpark, right?
Yeah.
So, that's just comes under the healthcare system that taxpayers that we provide that.
Yeah, it's like $300 or $400 or something like that.
For each.
Yeah, for each shot. It's
that's once
like
a month
that.
because you're giving one each to how many people, and that's once a month. So I'll just look. I mean, I'm in accounting, so I'm also
Yeah. So and it's completely paid for. Yes.
They don't pay. I understand that, but they meaning the person with addiction.
Yeah,
Yeah.
yeah. No,
But
it's,
someone's providing it is why I'm asking. It's it's
Yeah.
thousands and thousands and thousands, like where does it come from? It's
Mhm.
just under the health nurses.
yes, yeah.
So I was curious. I watched you give that injection to one gentleman and then, so I needed to know, I wanted to learn, I was in psych. And when he left, I approached the patient and I said, can you give me some insight? Because I'm not familiar with this. And what he said to me, and you'll know who it is when I tell you, what he said to me is I was up to 10, 11 dillies a day. He had explained what dillies were. I didn't even know what dillies were. Dilaudid, that's what dillies are. And he's a fisherman, and I kept functioning. And with this, I can function. But I mean, it was the second time. I know we had that firm. Does that injection site? Does that firmness, big lump? Does it eventually go away, or is
Yeah.
it always there?
No, it breaks down and goes away. Different for different people. Some people, it's gone by the next time I give a shot. So I
that
can't
was
even.
his only complaint was this one's still bugging me, but he was getting the second one, but it wasn't stopping him. Like he was going
No.
ahead because he does better in life on that.
Yep. Yeah. Nope. If you're really thin, they don't break down anywhere near as well, and so we do have to. I mean, for those individuals, I like to try to reduce the doses so that it's a smaller lump.
You said you got to
Okay.
curl up. So you had to give that to me. I have to curl up because you have to have.
Yeah, I do fun things to try to, make a little bit of a bulge. in that
But you're the
area.
only one
Yeah.
that's administering that in Pearl Burning, right?
No, I'm not the only
Oh,
one.
I
There's
thought
some
you were.
nurses that I've trained.
Oh, good for you.
I think I've trained 4 nurses to do it. Some of them don't live here anymore, but I think there's 2 nurses that I've trained that are still doing it here. So,
Even
yeah.
us that you got a
In
heavy
community?
load.
Yeah.
Okay.
Yeah.
Is there any possibility for like in-house, like in hospital? Because I know that you're here, you often do them.
Yep.
But I'm sure you have holidays and a life. Like if you're not here, you'd be providing that.
Yeah. No, I'm happy to show people how to do them. Yeah, because for instance, if someone was to come into Emerge and they'd missed their Sublocade from the week before, and they thought, you know what, I'm doing okay. But then on the weekend they start getting sweats and stuff like that, so they come in on the weekend to get a shot, and I'm out on Hornby. I can't come back to give a shot. So I mean, it would be great to have someone here. Now, it's not a disaster though, because we can also give the Sublocade under the Suboxone under the tongue until I do come back. So there is another way of making sure that they are covered, so they don't need to start reusing again. But if someone can give the shot, that would be great. So yes, easily there's the drug rep has a training course for it, but I mean I can show how to do it. It's not I don't know for your guys like for you guys to be able to sign off. I don't know if you have to have like it can't be, I don't know if you can just have me show you how to do it, or you actually have
I'm
to
sure
have
there's probably some paperwork that goes behind that.
I think there
but-
probably is, but yeah. But I'm happy to have more people do it for sure.
Yeah, like as a nurse that works on Merge, I was like, and I've seen another provider give it in an IMO before. So I was just curious, like, is that even in our scope of practice to do?
It's so long as you understand the underlying pharmacology and timing of it, then I think it's perfectly safe to do. It is different than any other injection. Like nothing. Like you have to really
It's
have
quite viscous,
confidence.
and it's quite a slow
Yeah.
injection.
Oh,
yeah.
I don't give it slow. I give it fast.
Oh, okay.
Yeah. Some people do give it quite slow. It is very viscous, but if I find a good plane to give it, I give it fast because I want to get that ice back on there as fast as possible.
Okay.
So yeah. So I generally speaking give it really fast.
What gauge needle do you use?
Oh, it's attached to it already.
It comes all
Yeah.
set up?
Yeah, it all comes set up. Yeah. Just do an alcohol swab over the top, pinch, lift, give
yeah,
the shot.
I've seen Dr. Elon's done a few.
Yep.
Like,
He
kinda-
likes to give
I-
epinephrine
Yeah.
to do it, and that's another way of doing it is epinephrine. There was a time that epinephrine was everyone was told you can't use epinephrine with it because there was some reaction with it or something, and then they went, oh no, that was wrong, you can use epinephrine again. But by that time I had been doing ice, and ice works really, really well. I find that it works really well anyway. Some people don't like to get more than one needle, so they would
Yeah.
rather
Yeah.
have the ice for that. And yep.
From a nursing perspective, like if someone gets their Sublocade, because I'm thinking of like a particular case that happened in the ER, like 24 hours later, they shouldn't be experiencing like extreme lethargy. Like they shouldn't be having, because I think in that specific patient presentation, they're like, well, I just got my Sublocade yesterday, that's why I'm like this. I was like, I don't think that's why. And I just wanted to make sure that they're, because it does take a while to start working, but it shouldn't work that.
Yeah,
potent.
I'm not aware of that being a
Yeah.
likely.
Are there other side effects to be aware of, or?
I mean, as long as you get it in the right spot. I mean, if it's too close to the skin, it can erode through the skin, and you can have it come out through the skin, and that can happen. But that's why we're careful with how we do it.
Yeah.
That's why we do that pinch and lift and create that potential space and give it in there. So yeah, so that's why it's important to get the shot right. Yeah.
Thank you for all you're doing.
Oh, my pleasure.
Those folks.
Yeah.
Yeah.
No, it's a really special job you do.
Well,
Not
thanks.
just the
Yeah.
shot.
Yeah.
Yeah, no, I don't know, you can probably tell by the way that I talk about it, is that it's really rewarding.
Yeah.
It's,
Yeah.
to see individuals that are like male and female being sexually assaulted multiple times a week and getting robbed all the time and beaten, and they're in a tent and they wake up to have people kicking them who are just like walking around kicking people in tents, and their family won't return their phone calls, and they feel like there's life's not worth living and they can't see a future. To go from there to back with their family again, and their self-worth, and they feel like they can contribute to society, and they become employed again, and they coach like kids soccer or kids hockey or something like that, like they used to do 10 years before. And there's many individuals like this, and it's quite funny because I play hockey. And without being able to disclose, obviously, from confidentiality point of view, I will be sitting there in hockey, and I'll hear some of the guys say things like, "Yeah, I had my chainsaw stolen out of the back of my truck. Bloody druggie did it," and all like this. And I was like, "Well, if you left your chainsaw in the back of your truck, it might have just been stolen by someone that wanted to take it to a pawn shop and make a little bit of money, or use it themselves. It wasn't necessarily someone that was using drugs."
Stigma's still
But-
there. I know.
Wow.
Is this over at 2?
I think
Yeah.
so.
Because I'm walking into another meeting at 2 and I'm gonna boot you out.
Oh yeah,
Oh,
we'll
okay,
leave them.
okay.
Yeah.
Sorry.
That's okay.
Okay.
Yeah. So there's so the individuals sometimes are in the room that I know were previous users that now no longer use, and they're back to playing hockey and they're doing great and all like this. And and I'm just thinking, man, they're listening to this and they're just thinking, yep, this is exactly what I lived through for all those years. And now they don't even know that I used to do this. I will sometimes go into a store, and the teller is someone I go, "Oh," and I don't acknowledge how I know them. I just like this. Or it's someone in a bank teller, or a tradesperson comes by my house to work on a dishwasher or something like that. And it's like, "Oh, hey, how are you doing?" And like this. And they were a patient of mine, or they still are a patient of mine. And then they come by and they're doing great. And you never would know that they ever previously were like on death, or had overdosed a number of times, and had sold their grandmother's wedding ring, and had had done all sorts of things which they really regret. So yeah, so people can really do really well.
Thank you, Shane.
Thanks.
Thank you.
Okay.